Okay, I have started recording this session and I'll introduce myself. First of all, I'm Dr. Amit Porwal and I'm Assistant Professor in the Department of Prosthetic Dental Science. I'm also the coordinator for the comprehensive course which is there in the 6th year. But for you guys, I'll be taking 2 of the lectures, that is in this week and next week, for the maxillary anatomical landmarks and mandibular anatomical landmarks. So, what are we going to do in these lectures? The intended learning outcomes behind these lectures. The very first point is we are going to, you should be able to identify the extra oral landmarks. The landmarks which are present outside on the face, these are known as extra oral landmarks. Then the maxillary supporting oral structures, maxillary peripheral oral structures, and also you should be able to understand the significance of all, that is the limiting structures, supporting structures, as well as the relief areas of the maxillary arch. So that is our intention behind this lecture. After this lecture, after hearing this lecture, you will come to know about all these things. Now, before understanding this lecture, you should be knowing few of the things that are known as prerequisites, that is the anatomy of maxillary bone. Okay, so how the maxillary bone is formed? It is formed by the palatal process. Okay, the palatal process of the maxillary bone. They come from both the sides and come and join in between. So there is a suture in between the maxillary bone or the palate, what we are having, the permanent palate. It has a suture in between, and we also have a primitive or the anterior palate. So it is made up of the different processes of maxillary bone. Now, what exactly is a complete denture? As you all know, there is a different stages, that is the dentulous state, partially dentulous state, and edentulous state. So edentulous state is that state where no teeth is remaining in the patient's mouth. So patient is completely edentulous. That is what we call. So when the patient is completely edentulous, we fabricate a prosthesis that is known as complete denture. If the patient is having few teeth, then the patient is known as partially edentulous, and that time we will be making a partial denture for the patient. Okay, so today we will be discussing about the complete denture or complete edentulous state and what are the maxillary anatomical landmarks. So there are various terminologies that are used for complete dentures, like the flanges or the teeth surface or occlusal surface, and the tissue surface. So there are some different surfaces of the complete denture that you need to know. The surfaces which will come in contact with the tissues and which will where the teeth will be placed. So there are different surfaces. Now there are various steps those are involved in the fabrication of complete denture. Throughout your complete semester, you will be learning about all these steps, but I would like to enumerate them here. That is, first of all, we make the impressions. That is, we try to register what is there in the patient's mouth, and then depending on that, we try to relate the jaws. So we have two bones, maxilla and mandible. So we try to relate these jaws, and that is known as jaw relation. Now, once we do the jaw relation, then we arrange a teeth and then we process the denture. So these are all the complete denture steps which will be taken throughout your complete semester, one by one. Now, the importance, why it is important, why knowing the anatomical landmarks is important, because once we understand these anatomical landmarks, it becomes very easy to communicate between each other and also with the laboratory, and also we know the importance of these structures which are present in the patient's mouth. So it becomes very easy that how much force has to be applied, where it has to be applied, which areas to be relieved. So once we know the importance of all of them, then it becomes very easy to provide a successful prosthesis to the patient. Okay, so we need to understand which are the foundations or what is lying beneath, on what structures we are making our prosthesis or the complete denture, because in order for that prosthesis to become successful in the patient's mouth, it should coexist with the other underlying tissues. So we need to understand the tissues, what type of tissues are those, and on which we'll be fabricating our complete denture. So we need to understand the anatomy of these structures so that we can fabricate our complete denture on these structures. First of all, I'll be discussing some of the extraoral landmarks. So let me clear one point here. What exactly do you mean by landmark is, these are the reference points. Like if we want to go from one place to another, we need to have some landmarks. Okay, so like if you want to go, I will give you an example. If you like to come from the dental college, our college, towards the airport, so always if somebody is asking the direction, we will say that you take the road from the dental college towards the Jazan, and from the Hyper Panda you take a right turn. Okay, so what does that mean? That Hyper Panda become a landmark so that you can discuss, and when you discuss, that other person can also imagine that point. Okay, from that point, so these are known as the landmarks. Now we will be discussing today the landmarks which are present on the facial structures, so that we can understand how they are related to our prosthesis and what consideration should be given to these landmarks. So I'll be discussing first the extraoral landmarks, that is the landmarks which are present outside on the facial structures. Okay, so first of all, the A part, these are known as the nares, okay, or the nostrils. B part is the rima oris, okay, so that is the mouth. C is the lower lip, you can see it here. D is the mentum, okay, and E is the mentolabial sulcus. So the sulcus, there is a sulcus which is present on the face, which is present between the mentum and the lower lip. So that's why it is known as mentolabial, between mentum and labial. So this is known as mentolabial sulcus. F is angulus oris, that is the corner of the mouth, also known as corner of the mouth. G is the upper lip. H is the philtrum. Now what is philtrum? It is a depression which is present on the center or the midline of the upper lip, that is known as the philtrum. I is the nasolabial sulcus, okay, the sulcus which is extending from the nose towards the labial side, so it is known as a nasolabial sulcus. And last one is the alegnesi, or the ala of the nose. So these are the names of the extraoral structures which we should be knowing. I'll be discussing them one by one here. So what is the need, or why we need to know the extraoral landmarks? So that the support to the lower third of the face is provided by the teeth and the soft tissues behind them. So what we need to understand here is, I will show you here the photographs. Okay, in this photograph you can understand that the first photograph is the lady's photograph where she is having normal teeth or dentition. But what happens when the age progresses? Maximum of the teeth are, and when all the teeth are lost, that is known as a complete edentulous state. So when the teeth are lost, there will be resorption of the bone also with those teeth. Okay, so what happens to the face? The lip, both the upper lip and the lower lip sags inside, and these are the facial features which we can see in the old age. Okay, so that is the effect of the loss of the teeth on the facial features. So here all these structures, the anatomical structures, are supported by the ridge, the bone and the teeth inside. But when the bone and the teeth is not there, when the teeth are extracted because of any of the caries or periodontal reason, and when the bone resorbs, this happens. So when we are fabricating our denture, we need to support these all extraoral structures so that it looks natural for that patient and it does not sag inside in the patient's mouth. So when natural teeth are lost, these landmarks and facial tissues becomes distorted. Now what is our goal? Our goal is to re-establish the normal appearance of these structures with the help of artificial teeth and also with the help of the complete denture or the flanges. First of all, the nasolabial sulcus. This is the sulcus that we are talking about, this sulcus. So what will happen if the teeth and the bone is lost? This upper lip is going to sag inside, the lower lip is also going to sag inside, so it will become more prominent always. Okay, so but this sulcus is a normal anatomical landmark on the patient's face. So usually when the patient comes, they will ask you to obliterate. So most people will ask us to remove this sulcus because it becomes very deep with the old age. But that is a normal structure. We should never try to remove it completely, but we can always support the upper lip so that the patient has some natural appearance, or it looks aesthetic on the patient. Okay, so this circle is normal. And did I skip? Who is this? Did I skip this slide? I think I explained you. Okay, there was a confusion. Somebody put a message here. Okay, we will continue. It becomes a wrinkle as the skin loses its resilience. Okay, so we were discussing about the nasolabial sulcus. Okay, so here this sulcus becomes more prominent with the age when the tissues and the teeth are lost because of the sagging of the upper lip and also of the lower lip. This becomes more prominent, but when we are providing a complete denture, we should try to support this area complete, the lower third. This is known as the lower third of the face, so we should try to support. Now what we can do is to reduce its depth. Complete denture, what the complete denture should be having, a proper vertical dimension. So the proper vertical height should be there. Tooth position should be placed properly. So wherever there is loss of the bone, we should be placing our teeth. And also the thickness of the flanges. So when we fabricate our the complete denture, the flange thickness also should be good enough so that it can support the lips properly. Now here you need to understand these all terminologies you will be listening for the very first time. So it becomes difficult as of now in the very first lecture to remember all of them. But as you progress throughout the semester, all these things will kept on repeating for you. So at that time it will become very easy to understand which are these structures and their names. Here like in vertical dimension, you might not know now because the vertical dimension, it comes in a fourth here, but here I am just placing it here so that you need to know that when you want to reduce the depth of the nasolabial sulcus, these are the factors that you need to consider when you are making your complete dentures. I think in the practicals also, doctors who are there, they will be discussing these for at least 2 weeks, the anatomical landmarks. So again, a discussion will be done for you guys on all these anatomical structures. Now the second maxillary, the extraoral structure is the mentolabial sulcus, that is which is present between the mentum and the labial or the lower lip. So when the lip sags inside, this mentolabial sulcus also becomes prominent. So here in this schematic diagram, you can see if we provide a maxillary denture and a mandibular denture, this is the labial flange of the denture, that is which supports the lip. That's why it is known as labial flange. And we also have a lingual flange here of the denture. So denture is having a labial flange and a lingual flange. So the labial flange should support the lower lip. Here also the labial flange should support the upper lip, so that whatever is the sagging of the upper and the lower lips, this sagging can be reduced. You cannot remove the complete sagging in all patients, but we should try to support these structures so that they can give a normal appearance to the patients. Philtrum. Now what is philtrum? Philtrum is a vertical groove or a depression which is present in the midline on the upper lip. Okay, so this is known as the philtrum. Now with the loss of the teeth, this becomes flattened, so it doesn't look prominent, it is very much flattened. Now what you have to do is when you're arranging teeth for the patient, you have to arrange teeth and flange in such a way that it will restore the normal curvature. So it should look like a depression in the midline when you have placed your complete denture. In this photograph you can see this is where the lips have been supported too much. So now what this excessive support can do, it can distort the philtrum. So the depression will not be there. So always when you are fabricating your complete denture, you have to see that the philtrum should appear in its normal position. That is, a normal depression should be there on the upper lip, and it should not be removed completely. The lips, this point we have already discussed. The upper lip and the lower lip sags inside. The lips are folded inward, so proper denture thickness, flange thickness for the anterior and the anterior teeth position should also be proper, so that it can support the upper and the lower lip. Modulus. Now, what exactly is modulus? You might have read this in your anatomical courses. Modulus is a junction, or it is a meeting point for 8 muscles, and it is located near the corner of the mouth. So what these 8 muscles do? They come and join here near the corner of the mouth, and that point is known as modulus. Now, how does this modulus is related to our complete denture? Whenever the buccinator muscle or the cheek muscle, it contracts, it fixes this modulus. So how does it help? Like whenever we are drinking water, or whenever we are eating food, we always contract this modulus. Why we contract this modulus? Because the food is present in the cheek area. So when we contract this area, the food is not going to come out of our mouth, either when we are eating or when we are drinking. So always you try to swallow. What happens? The very first thing that happens is this modulus is locked against the teeth, so that the water or any of the food does not go out, and this point becomes a fixed point. So modulus becomes fixed every time the buccinator muscle contracts. So it is supported by the arch form of the maxillary teeth. So it is supported, and contraction of the modulus presses the corner of the mouth against the premolars. So when the teeth are present, it contracts the mouth against the premolars, so that the occlusal table is closed in the front and the crushed food cannot escape. So this is a very important anatomical feature that helps us in eating and drinking water when we drink water. Now, what is the significance of this? Now, whenever you have either a seventh nerve damage or a palsy, or whenever you have given an inferior nerve block, at that time the patient might show some features of drooling of saliva. Okay, so that drooling of saliva means saliva comes out, means patient doesn't have control of this modulus. So the patient cannot control the water or the saliva in the mouth. So if the patient drinks some water, or if the patient is having saliva, it will drool from the corner of the mouth. So the importance of this can be seen at those times. Now, with the loss of teeth, it drops, giving the characteristic sunken cheeks. So the practical approach to counteract this lies in estimating the height of the occlusal plane and developing the polished surface. So once we have this area, okay, now when the teeth and the bone is lost, so when we are fabricating our complete denture, we need to provide space for this modulus, so that this modulus can contract properly against the flanges of the denture, and they can fix against the denture, so that the patient can eat and drink water in a normal fashion. Now, about the tragus and the pupil, we also need to consider two more anatomical points. First of all is the alar tragus line. It is an imaginary line. Now, we have already seen this part of the nose is known as the ala of the nose. Okay, and we have one part here on the tragus, that is, tragus is present in front of the ear, and elevation which is present in the front of the ear. So if we see an imaginary line, this line is not present on the patient's face. If we combine this imaginary line, we will be having a ala tragus line, and this line is used when we do our orientation jaw relations. Okay, so you just need to know the name of this line as of now. In detail, it will be discussed in the coming lectures. Then there is one line which is known as interpupillary line, that is the line and imaginary line which passes from both the pupils. Okay, so this will show us the anterior plane of the occlusal rim when we are making our complete denture. The alar tragus line will show us the posterior plane when we are making our complete denture. Now coming on to the intraoral landmarks, that is the landmarks which are present inside the patient's mouth. Till now we were discussing all the extraoral landmarks. Now in the intraoral landmarks we have three different types of landmarks, that is the limiting structures, the supporting structures and the relief areas. Now in my next slide I'll show you what are the limiting structures. Okay, so this is a maxillary cast. Again, which slide do you want? 15. Okay, these are two structures that I have discussed here. See, in the eye we have pupil in the center. Okay, so we need to consider here one imaginary line that will be used during your complete denture fabrication, that is known as interpupillary line, which passes through both the center of the pupils. So it is an imaginary line when you are fabricating your complete denture. I am just discussing here so that you need to know that these are also a part of your extraoral landmark. So this is interpupillary line. You can see it here, a line which joins. It is an imaginary line. It is not present on the patient's face. Same here, second imaginary line is the ala tragus line. So a line which joins the ala of the nose to the tragus of the ear. It is also an imaginary line. And if you combine these two with the help of a ruler or a scale, then you can fabricate your occlusal rim posterior part with the help of this. So when you come to the jaw relations, the importance of these two lines will be discussed with you in that particular lecture. Now coming on to the intraoral structures, I have discussed there are three different types of structures, that is the limiting structure, supporting structure and relief area. Now what are limiting structures? Limiting structures are those structures which limits the extension of the denture. So this is a cast, a maxillary cast which is shown here. Now when we fabricate our complete denture, so that complete denture will be replacing whatever is the missing structures of the bone as well as the teeth. So it will be having flanges, okay, and it will also be having the teeth. So the areas which will limit the extension of our denture are known as the limiting structures. Can you see the mouse running around? These are all the limiting structures. It means till which area your denture is going to be limited, or till which area your dentures are going to be extended. So these are known as limiting structures. The second structures are the supporting structures. The supporting structures are those structures where you can apply force, or when the patient is wearing the complete denture or when the patient is eating with the complete denture, the forces on these areas can be applied so that there is no resorption of the bone and patient can chew or masticate properly. So these are known as the supporting structures. Then in the end we will be discussing the third type of area. These are known as the relief structures. These are the structures which needs to be relieved. It means there are some important structures which are present beneath these areas. So we'll be discussing one by one all the three different types of structures. First of all, we'll be discussing about the limiting structures. Now what are the limiting structures? These are the sites that will guide us in having an optimum extension. It means it tells us that till where we are going to extend our prosthesis or the complete denture in the patient's mouth, okay, so that we can extend maximum to the physiological areas where we can extend it, okay, and there are no muscle actions on which we can encroach. So if there is any muscle and if we don't record at the time of complete denture making, then what will happen? As soon as the patient moves his mouth, the complete denture is going to fall down from the mouth, okay. So we need to understand these limiting structures till where they are extended and how much we should extend within these limiting structures. Now, the mucosa of this species is classified as lining mucosa. It is normally non-keratinized. We have keratinized on the alveolar ridges, but here we have non-keratinized layer with loose submucosa and elastic lamina propria. It means that here the mucosa is very loose, and if we apply too much pressure, then these area can be overextended. But later on, what is going to happen? Either the denture is going to lose its retention, or it is going to traumatize the tissues. So we need to be very careful when we record these limiting structures. So encroaching upon these structures will lead to dislodgement of the denture or soreness in the area, while failure to cover these area up to the limiting structures will imply decreased retention. So if we don't encroach upon these structures also, what will happen? The retention will be lost. It means the air will pass between the tissues and the denture, and the denture is going to fall down. So we are going to lose retention, stability and support for the complete denture. Now there are 6 different types of limiting structure. I'll be discussing here on this cast photograph. Okay, so here first is the labial frenum, a frenum which is present at the center of the maxillary. This is known as labial frenum. Second, we have buccal frenum here. Okay, so which is related to the cheek. This is known as related to the lips. That's why it is known as labial frenum. This is related to the buccal or the cheek. That's why it is known as buccal frenum. Now, the area which is present between the labial frenum and the buccal frenum is known as the labial vestibule. Okay, here our labial flange of the denture is going to come. So this is labial frenum, labial vestibule. Then we have buccal frenum. The buccal frenum can be either 1 or 2. Okay, so it depends upon patient to patient, from side to side. It can be 1 or 2. Then after the buccal frenum, we have the buccal vestibule. This completely is the buccal vestibule. Then in the posterior part, we have maxillary tuberosity is here. Okay, I'll be discussing that in the supporting area. We have maxillary tuberosity here, and we have a hamular notch. A notch which is present behind the maxillary tuberosity is known as hamular notch. Okay, and in the center we have the posterior palatal seal area. So these all structures are the limiting structures for the maxillary arch. Same on the other side. So we have the labial frenum, labial vestibule, buccal frenum, buccal vestibule, hamular notch, and the posterior palatal seal area. So these all are the limiting structures. It means our denture should be extended till here, and it should not extend beyond these structures. That's why these are known as limiting structures. Now, what is labial frenum? It is a fold of mucous membrane. This is a clinical photograph. You can see it is a fold of mucous membrane which is present on the maxillary in the midline area. It contains no muscle. It doesn't have any muscle, and it performs no action. But what happens? It is fan shaped. It is fan shaped. So whenever you try to retract the upper lip, then it will look like as a fan shape, and it attaches on the labial side of the ridge. So it attaches here. So what we have to do is, here in this photograph you can see here, this is the maxillary denture which is there in the patient's mouth. So we need to provide a notch in the denture. If we don't provide a notch, and if we fabricate our denture straight here, then what will happen? Whenever the patient tries to move the lip or the upper lip, this action of this labial frenum will force the denture down, and the denture is going to fall from the patient's mouth. So that is known as the loss of retention for the denture. So always we need to provide a notch for this labial frenum. It is just a fold of mucous membrane which is present in the midline of the maxilla. So clinically, a V-shaped notch is recorded. So this is an impression that you will be seeing in your impression section of the complete denture. When you make an impression, a notch will be recorded here because of the movement of the labial frenum. So the same notch should be present in your complete denture. so as to provide some space for the movement of the labial frenum. Now the labial vestibule, it is a vestibule. It is that portion of the oral cavity which is bound on one side by the teeth. So in the dentulous state we have teeth here, okay, teeth, gingiva, alveolar ridge. So on one side it is bounded by the teeth, gingiva and alveolar ridge, and on the other side by the lips and the cheek. So we'll be having our cheek here in this area, and we'll be having our lip in this area. So this is covered on the inside part by the bone, by the teeth, by the gingiva, and on the outside by the lips and the cheek. Now in the lips and the cheek we have different types of muscles. So outside it will be in contact with the orbicularis oris. Okay, so we'll be discussing it here. And the vestibule is covered by the lining mucosa. So here this vestibule is also covered by the lining mucosa. Some mucosa is very thick in this area and contains areolar tissue elastic fibers. So again it is a limiting structure, and some mucosa in this area is very thick. Now how are we going to record in clinical? See, this is a clinical photograph. This is the labial frenum, this is the buccal frenum. So the area which is bounded in between is known as the labial vestibule. Now the main muscle of the lip, here the lip is there outside, okay. So the main muscle of the lip is the orbicularis oris, okay. So that forms the outer surface of the labial vestibule. So this is the labial vestibule. Inside part is the bone part, and outside part is the main muscle of the lip, that is known as the orbicularis oris muscle. Now this orbicularis oris muscles, they run horizontally and have indirect displacing effect. So whenever we are trying to record this labial vestibule, we need to make the movements of the orbicularis oris muscles so that these areas are recorded properly, and this will not interfere with the movement of the muscles around. So the muscle tone, it depends upon the support. So what support are we going to provide in the complete denture from this area? The muscle tone, orbicularis oris muscle tone, depends upon that. So always the position of the flange in this area and the position of the teeth is more important to support the muscle in this area. Same like labial frenum, we have buccal frenum. It forms the dividing line between the labial vestibule and the buccal vestibule. So in between we have the buccal frenum. It can be a single fold or it can be double fold of mucous membrane. Now clinically when we see, we have different insertions of the muscles here, okay, beneath it. First of all, we have levator anguli oris, which lies beneath this fold of mucous membrane. So we have levator anguli oris muscle. Then we have orbicularis oris muscle. This orbicularis oris muscle is the muscle of the mouth, okay. So the muscle of the mouth also comes and attaches here in this area, in the buccal frenum area, and it pulls the buccal frenum anteriorly in the forward direction. And we have the buccinator muscle also, which is attached here, and it pulls the frenum posteriorly. So what is the implication of this, or what is the significance? The significance is that it requires more clearance of the buccal notch. Same like the labial notch, what we have provided, we need to provide a buccal notch in the denture. So this is a denture, what you are seeing. We need to provide a buccal notch here, which should be broad, because in anterior side the orbicularis oris muscle will be pulling this frenum, and posteriorly the buccinator muscle will be pulling this area. So we need to provide a bigger notch area in our denture. That is the significance of this buccal frenum. Next is the buccal vestibule. Now it extends from the buccal frenum and posteriorly it goes to the hamular notch area. Now which is the hamular notch area? Hamular notch area is that area which is present behind. So here if you see, the hamular notch area is this area which is present behind the maxillary tuberosity, okay. So the area which extends from the buccal frenum to the hamular notch is known as the buccal vestibule area. Now when we are trying to record this area, its size varies because of the buccinator muscle, because buccinator muscle is the cheek muscle, complete cheek muscle, it is known as buccinator muscle. So how much active is the buccinator muscle? The thickness of the flange in this area is recorded by the help of the buccinator, contraction of the buccinator muscle. Then the position of the mandible, this I'll be discussing in the next slide, and the amount of bone loss. So how much bone loss is there? If the bone is resorbed too much, then this area is going to be very thick. If the bone is not resorbed in this area is going to be very thin. Now how the position of the mandible is related to this? Here in this skull, you can see here we have a condylar process and we have a coronoid process of the mandible. So this coronoid process comes in contact in this area of the maxilla which we are discussing, this area. Can you see? So this is the coronoid process of the mandible. So when the patient moves the mandible from right to left side, the thickness of this area decreases. So what is the significance of this? When we are recording this area, we should ask the patient to move the mandible from one side to another so that we can record the thickness of this area, that is known as the buccal vestibule area. So it depends upon the thickness of the bone, also onto the movement of the mandible. So it should be measured with all the possible movements of the mandible. Next is hamular notch. What is hamular notch? It is a depression which is present beneath the tuberosity area. It can be palpated here, like you can see here, with the help of a mouth mirror or with the help of a T-shaped burnisher. You will be seeing this T-shaped burnisher in the clinics, so you can palpate with the help of that. Okay, so this depression you have to palpate, and that is the hamular notch area. Now the mucous membrane of this hamular notch consists of thick submucosa which is made up of loose areolar tissue. So it is made up of thick submucosa, so we can apply our pressure. It is one of the limiting structures. So it is this structure that we are talking about. It is the hamular notch area. So what we are supposed to do? We are supposed to mark this area in the patient's mouth with the help of a pencil. Okay, so here what you can see here, it has already been marked in the patient's mouth with the help of pencil. And when we try to record it, that area should not be extended more, because if you extend it more, then as soon as the patient moves the mouth, or as soon as the patients open the mouth wide, the denture is going to fall from this area. So we need to be very careful while extending our denture in this area. If the denture is placed, if the denture border is placed anteriorly, it will also lose its retentive. So it should be extended properly. It cannot be more, it cannot depress this area more, or it cannot be short in this area also. Okay, so we have to be very careful while recording this area. Now posterior palatal seal area, this is the area which is present in between the both the tuberosities. Okay, so this complete area is known as posterior palatal seal area. This is the area where the soft tissues at or along the junction of the hard and soft palate. So if we go here in the previous slide, we have hard palate here and we have soft palate here. So it is this area which lies at the junction of the hard and the soft palate, where we can apply pressure so that this area can provide retention to the denture. Okay, so when we apply pressure, it can be applied to the denture to aid in retention of the denture. So we can apply pressure in these area, and this posterior palatal seal area should be recorded properly. If this area is recorded properly, it prevents the air entry between the denture base and the soft palate. So this is the complete posterior palatal seal area. It has two different parts. First is the pterygomaxillary seal. It extends cross the hamular knot. This is the pterygomaxillary seal, and extends 3 to 4 millimeter anterolaterally. So this is the pterygomaxillary seal, and which is present in between the tuberosity. This area is known as the post-palatal seal. You will be having a complete lecture on this posterior palatal seal area, a single lecture describing every feature of this landmark. But now you need to know that this is the posterior palatal seal area, and it has two parts, that is the pterygomaxillary seal here and the post-palatal seal, which is present between the tuberosities. Now we have vibrating line. This vibrating line, we have to see what is this vibrating line. It is an imaginary line. It is not present in the patient's mouth, but when you are trying to record, you have to see it in the patient's mouth, and you have to mark it with the help of a pencil in the patient's mouth, so that you can record it on your impressions or on your denture. Now what is this imaginary line? It is drawn across the palate that marks the beginning of the movement of the soft palate. So we have hard palate here and soft palate. So there is beginning of the movement of the soft palate in this area. So we have to mark this line, and it should be extending from the hamular notch, from one hamular notch to the another hamular notch, and it lies usually 2 millimeter in front of the fovea palatini. We'll be discussing what is fovea palatini now. So this vibrating line should be marked in the patient's mouth, and our denture should be extended till here. That's why I am discussing it here. It is one of the limiting structures. Now the distal end of the denture should extend at least to the vibrating line. So whatever we have marked here, the denture should extend. So it is one of the limiting structures. Now what is the function of this posterior palatal seal area? Posterior palatal seal area is the thickness, this area complete. But what is this? This is the vibrating line. This is the distal most extension of the posterior palatal seal area. Now what does this area does? It helps in the retention. It means it will not allow the air to go inside from this area. It will not allow the food to go inside from this area. It will also compensate for the polymerization shrinkage. What does it mean? It means that when we process our denture, the acrylic can shrink away from the tissues. So if it shrink away from the tissues, there will be gap here. So if we record this area in a depressed state, even that it will compensate. Whatever shrinkage is going to happen later on, it will shrink, it will compensate that also. And it will also reduce the tendency to gag. Okay, so there will be no gagging if we don't extend our denture beyond this point. So those were the limiting structures, that is the areas which limits the extension of our complete denture. The second type of structures are the supporting structures. It means the load bearing areas, or the areas which show minimal ridge resorption. It means there is very less resorption of the bone in this area, even if constant load is applied. So we have to fabricate our denture in such a way that we have to focus our force only on these areas. Okay, now these areas are also defined by the mastigatory mucosa. It is characterized by the well defined characterized epithelium and lack of the tissue movement. So there is no movement, and it is bounded by the mastigatory mucosa. Now the mucosa of the residual ridge is formed by the keratinized stratified squamous epithelium and the adjacent narrow layer of the connective tissue known as the lamina propria, that we have already discussed for the previous structures also. Now these ridge crest tissues are from remnant gingival tissue. So earlier what was there? Earlier we were having the teeth and the gingiva in these areas, but now when the teeth and the gingiva is lost, these are the remnant of those tissues, and these are excellent stress bearing tissues. It means how much amount of force is applied to them, these areas are not going to resolve. Now these stress bearing areas are divided into two, that is primary stress bearing area and secondary stress bearing area. Now what are the primary stress bearing area? These are the areas where you can apply maximum force when you are fabricating your complete denture. It has thicker mucosa, and the bone underlying is cortical type of bone. Okay, so this cortical type of bone does not resolve. So the very first structure, which is the primary structure, primary stress bearing area, is the hard palate. Now which part of the hard palate? Not the complete hard palate, but the horizontal portion of the posterior palate. So this is the anterior palate area and this is the posterior palate area. So the horizontal portion of the posterior palate area, which is lateral to the midline, see this is a midline, so which is lateral to the midline, is the primary stress bearing area. This, the trabecular pattern of the bone here is perpendicular to the direction of the forces. So when the occlusal forces, or when the patient starts eating or applying forces on the complete denture, the direction of the trabecular pattern is perpendicular to it, so that it can withstand and there will be no resorption of these areas. So maximum forces should be diverted to these areas in the hard palate. So that's why it is known as primary stress bearing area. The second stress bearing area is the maxillary tuberosity. This is the tuberosity like thing which is present at the distal end of the maxillary arch or the maxillary bone. Here this is the clinical photograph. You can see these maxillary tuberosities. This tuberosity is often are dense fibrous connective tissues with minimal compressibility. So these areas are also not going to be compressible, and these are very stable areas. That's why they can be used as primary stress bearing areas, because these are least likely to resolve. Secondary stress bearing areas are there are two types again the rugae. So we have the anterior part of the palate. This palate has several mucosal folds. Okay, so when you see the clinical photographs or when you see the cast, you can see the mucosal folds in the anterior part. This is known as the rugae area. Okay, so this rugae area is considered as a secondary stress bearing area. Now why it is secondary stress bearing area? Because the palate is set as at an angle here. It is not flat here, it is set at an angle, and it is very thinly covered by the soft tissue. So you cannot apply too much pressure also, otherwise you will traumatize the soft tissues in this area. So these are not the primary stress bearing area, but you can always consider them as secondary stress bearing area. It means you can apply your forces but within limit in these areas. Second is the residual ridge. So whatever ridge, what is remaining after the teeth are extracted. So after the resorption or after the teeth are extracted, that is known as the residual ridge. Okay, now in this residual ridge, we'll be having a cortical bone on the labial side, but here in the center, we'll be having a cancellous type of bone. So when forces are applied, again these areas might resolve. So we cannot consider these area as our primary stress bearing area, but we can always consider these areas as secondary stress bearing areas. So the residual ridge is considered as a secondary stress bearing areas. Now the last and the third different type of anatomical landmark is the relief areas. Now what are these relief areas? These are the areas which have some anatomical landmarks which are present beneath these structures. So you cannot apply force in these areas. Like the primary stress bearing areas, you can apply force while fabricating the complete denture. But these are the areas either they are going to resorb or they have fragile structures which are present beneath them. So these are four different types, and we should relieve these areas or we should not apply pressure in these areas. First is the incisive papilla. It is a papilla like thing which is present in the center in the maxillary arch. Second is the mid palatine raphe area. This is the mid palatine raphe area where two process of the two maxillary process come and join. So we have a suture here in the between. So we cannot apply force on the suture area. That's why it is the mid palatine raphe area where we have a raphe. Third is the fovea palatini. This I will be discussing. And last is the torus palatinus. So in the incisive papilla, see this is the papilla which is present in the midline area. This is the clinical photograph. This is present in all the patients. Now what is the significance of this? Why it is a relief area? This is the exit point of the nasopalatine nerves and vessels. So from this the nasopalatine nerves and vessels comes out and goes on both the sides of the palate. So if you apply pressure on this rugae area, what is going to happen? It is going to cause paresthesia of the anterior palate. So what do you mean by paresthesia? It means this area will become numb if excessive pressure is applied on this area. That's why it is known as the relief area. The incisive papilla is known as the relief area. Second is the mid-palatine raphe. I have already told you. This is the suture area, median suture area covered by thin submucosa. The submucosa is very thin. So if we apply pressure in this area, this thin submucosa will be traumatized, and then the patient will be having ulcers in this area. So we cannot apply pressure. So it is also a relief area because the submucosa is very thin. Third is fovea palatini. Now, what are these fovea palatini? These are two depressions which are seen in the posterior part of the palate. Now, from what these two depressions are made? These are the openings for the salivary gland ducts. Okay, so whatever the mucous glands are there, several mucous glands which are present there, they will combine and they will come out via one duct, and this is the opening for that duct. So the saliva or the mucous glands opening is this, and all the thick or ropey saliva comes out of these glands here from the palate area. So our denture should not extend on these fovea palatini. So these areas should be relieved, and our denture should be approximately 2 millimeter anterior to these areas, to the fovea palatini areas. That's why these areas should be relieved, should not be extended upon. And the last is the torus palatinus. So what is the torus palatinus? It is generally seen in 20% of the patients. It is not a normal structure, but it can be seen in some patients. And what is it? It is the hard bony enlargement in the midline area. Okay, so it is a bony enlargement, and here the submucosa is very thin. So when the denture is fabricated, if we apply pressure, it can get traumatized very easily. So what we have to do, this area has to be relieved beneath the denture we are making. So this also becomes one of the relief areas, so that we cannot apply pressure in these areas. And lastly, if there are any undercuts or sharp bony prominences. Sharp bony prominences means when the teeth are extracted, maybe some of the bones, they remain sharp in that particular area. So if any of these things are there, those sharp bony prominences should be relieved. Otherwise, if you apply pressure on those areas, what is going to happen? Every time you apply pressure, there is going to be ulcer, and it is going to pain to the patient. Okay, so always you need to check for the undercuts. If there is an undercut or sharp bony prominence, then you have to relieve these area also in the patient's mouth. So this is just a recap, the summary of what we have discussed. We have discussed the anatomical structure, that is the extraoral structures, as well as the intraoral structures. Intraoral maxillary structures we have discussed. So these are divided into three, that is the limiting structures. Limiting structures are these structures which are surrounded, which surrounds the maxillary arch and which limits the extension of the denture. That is the labial frenum, labial vestibule, buccal frenum, buccal vestibule, hamular notch, and the posterior palatal seal area. So it is the same, all the limiting structures. Then the supporting structures. Okay, primary stress bearing area we have discussed. Primary stress bearing area is the hard palate as well as the tuberosity, and secondary stress bearing area can be the rugae area. Then the relief areas, incisive papillae, we have the mid-palatine suture area, the fovea palatini, and if a torus is present in the patient's mouth, that areas needs to be relieved. So these are different type of structure that we have discussed for the maxillary arch, and in next lecture we'll be discussing about the mandibular arch. All these structures are the same for mandibular arch, but we'll be discussing it in detail. Now the reference for this complete lecture is from the Tsar Hop Kit. It is the 13th edition, and the page numbers I have mentioned. This lecture has already been uploaded by Dr. Saurabh, so you can read it. And if you have any confusion, I have provided my email address. You can always contact me on that email, and also during my office hours you can contact me. Thank you.